We will discuss the importance of urea cycle, its steps, its regulation and energetics, and finally the defects in this pathway. Starting with the introduction, main purpose of urea cycle is to detoxify ammonia into a comparatively less toxic compound, that is urea. Ammonia is produced by the breakdown of amino acid and proteins. It is continuously happening in our body. Urea cycle mainly occurs in the liver that helps to eliminate excess nitrogen safely through urine. So, this is the introduction part. Let's move to the importance of urea cycle. Ammonia is generated from the major sources like dietary protein, breakdown of protein in our body, endogenous proteins, that is from intestinal secretion. All contribute to finally the amino acid pool, and then it is converted to urea. 57% of the nitrogen is converted to urea, and the rest is utilized is utilized for plasma protein synthesis and body protein synthesis, also in circulation. This shows why the liver is the major organ responsible for ammonia detoxification. So the fate of ammonia, as we know, ammonia can't be circulated freely in the form of NH3. It can't be circulated, so it need to be converted to glutamine, alanine in skeletal muscle, and glutamine in other organs in brain. So then it is transported to liver, in which glutamine is converted. Glutamine is With the help of glutamine it is converted to ammonia, and alanine participates in glucose alanine cycle and release ammonia. The process prevent ammonia toxicity. So, if ammonia toxicity occurs, hyperammonemia occurs. To remove excess ammonia, our brain combine ammonia with alpha ketoglutarate to produce glutamate and finally to glutamine. Since alpha ketoglutarate is an important intermediate of TCA cycle, its reduction can reduce ATP production, and secondly, GABA also decrease, which cause tremor, slurred version, slurred speech, and if it is extreme, it may also cause coma. And if there is increased level of glutamine, it can also cause encephalopathy and edema of brain. So I pass the mic to Shona to explain the rest.
We have come into the main urea cycle. So the main goal, the waste nitrogen which we have to excrete from our body in the form of urea. Urea in the molecule, we have seen that it contains two nitrogen. One nitrogen comes from free ammonia and the other nitrogen comes from the aspartate, which we will subsequently see in the cycle where it follows. Glutamate, as we have seen, is the precursor. So what it means that the aspartate aminotransferase, the glutamate is being converted to alpha ketoglutarate in the presence of aspartate transaminase. From here, through the oxidative deamination of glutamate, the free ammonia comes, which forms the first source of nitrogen in the urea. For the side, we just have to know that it takes place in liver hepatocytes, where the main urea cycle consists of 5 steps, where the first 2 steps happen in mitochondria and the last 3 steps takes place in cytosol. First reaction, which is important. Why? Because it is the rate limiting step of the whole cycle, where the ammonia in the presence of carbonyl phosphate synthase is converted to carbonyl phosphate. Here, the first nitrogen of urea comes in the form of ammonia, and this reaction takes place by utilization of 2 ATP. Second step. Second step, the carbonyl group that was formed in the first step, carbonyl phosphate, reacts with ornithine to form citrulline. In the presence of enzyme ornithine transcarbamylase. Here, the notable fact is that the ornithine, it is the second step which takes place in the mitochondria. This ornithine comes into the mitochondria via a transporter or via a soluble membrane transporter. Here, the ornithine, in the presence of ornithine transcarboxylase, it reacts and it forms citrulline. Third reaction, the citrulline which was formed in the mitochondria, it comes in the cytosol where citrulline is converted to arginosuccinate in the presence of enzyme arginosuccinate synthetase, and the ATP requirement, one ATP is converted to AMP, which is equivalent to utilization of 2 ATPs. And here aspartate also comes back, the alpha amino group of aspartate, which forms the second nitrogen source of urea.
So now I will be continuing from the third reaction, that is cleavage of the arginosuccinate. So arginosuccinate is cleaved in the presence of enzyme arginosuccinate lyase into two compounds, that is arginine and fumarate. The arginine is the precursor of the urea which will be formed, and the fumarate gets converted into malate, then oxaloacetate, and then it eventually it will go into the TCA cycle and it will give 1 NADPH. Then after that, here comes the fifth reaction, that is the cleavage of the arginine. So arginine is cleaved in presence of enzyme arginase, and in the presence of enzyme arginase and in presence of water. So this reaction is also called the hydrolyzing reaction. It will give ornithine, and the main product which it will give is urea. After that, here comes the fate of the urea cycle. After comes the fate of the urea cycle. So the main purpose of the urea cycle was to convert the toxic ammonia into its lesser toxic form, that is urea, so that it can be excreted easily. The urea is formed in liver, then through blood it is transported to the kidneys, and then it is excreted out through urine. Here we can see the overview of the total urea cycle, which occurs in two locations. That is, one is mitochondria, and the first two reaction in mitochondria, and the last three reaction in cytosol with the help of certain enzymes, so that ammonia can be degraded into lesser toxic form, that is urea. After that comes the regulation of the urea cycle. The regulation of the urea cycle mainly takes place through two processes. One is coarse regulation and the other is fine regulation. In the fine regulation, there is an activator, that is NAG, N-acetyl glutamate. It will activate CPS1 enzyme, that is carboamyl phosphate synthase enzyme, which will help the ammonia to degrade into its immediate less toxic form, that is carboamyl phosphate. And here come the coarse regulation. In the coarse regulation, the genes of the enzyme which are responsible for the urea cycle will get induced, so that the activity of the enzyme increases, and after which we can increase the urea production. Then last is the energetics of the urea cycle. So from the first reaction, we utilize 2 ATP. In the third reaction, 1 ATP is converted into 1 ATP is converted into AMP, which is equivalent to 2 ATPs. And in the fourth reaction, the fumarate which is formed, which goes into the TCA cycle, will form 1 NADPH, which is equivalent to 2.5 ATP. So the net ATP production is 2 ATP plus 2 ATP minus 2.5 ATP is equal to 1.5 ATP. Now I will pass the mic.
I'm roll number 122 and I will be continuing from here. So disorders of the urea cycle. in the urea cycle occurs due to the effectivity of the many enzymes. So defect in any kind of enzymes will lead to the accumulation of the previous substrate. In biochemistry, we know that any substrate upon activity of the enzyme converts into a product, and due to the deficiency of the enzyme, this substrate will accumulate and it will give rise to many metabolic disorders. Normal urea in blood, normal urea in blood is 5 to 35 micromole per liter. But in the cases of hyperammonemia, that is severe hyperammonemia, that is the deficiency of the carmyl phosphate synthase or ornithine transcarbamylase, the level exceeds 1000 micromole per liter. The general characteristics of the urea cycle disorders includes the in infants it will include the vomiting, it will lethargy will set in, failure, and there will be finally the failure to thrive, and in the end there will be orotic aciduria as well. But in the case of acquired urea cycle disorders, that is in case of the liver incapabilities, like the liver cirrhosis, like the liver nephrotic syndromes, there will be the deficiency of many enzymes like the ornithine transcarbamylase and the arginine synthesis. Now in the infants, there will be the now and our brain especially is mainly sensitive to these high elevated levels of ammonia, due to which there will be slurring of the speech, there will be tremors, there will be seizures, and there will be due to accumulation of the glutamine, there will be the glutamine as a osmotically active substance. It will accumulate water into the brain and as well as CSF, so it will lead to the cerebral edema as well. Now coming from the first one, the hyperammonemia type 1. In this hyperammonemia type 1 disorder, there will be the defect in the ornithine. There will be the defect in the carmyl phosphate synthase 1, which is converting NH3 plus CO2 to form the carmyl phosphate. This occurs in the one like incidents, and there is a carmyl phosphate synthase is the rate limiting step of the urea cycle, which is regulated by the N-acetyl glutamate. So in the cases of the N-acetyl glutamate synthase enzyme will lead to the N-acetyl glutamate deficiency, and it will mimic the hyperammonemia type 1. In the hyperammonemia type 2, the enzyme which is deficient is the ornithine transcarbamylase, which is also the second reaction of the urea cycle. Due to which it is an X-linked disorder mainly found in the males, and in there will be the increased glutamine levels, and there will be the orotic aciduria, due to which the carmyl phosphate will be channeled to the pyrimidine pathway. How? Orotic, there is the glutamine plus CO2. Glutamine plus CO2 in the presence of carmyl phosphate synthase 2, which will lead to the uridyl monophosphate. That's a pyrimidine pathway. And in the end, due to the pyrimidine pathway synthesis, there will be the excess secretion of pyrimidine, and there will be pyrimidine secretion through urine. Now coming to the hyperornithemia. Hyperornithemia will also called the HHH syndrome. And hyperornithemia, the defect is in ornithine transporter. The ornithine transporter is doing what? The ornithine transporter is transporting the ornithine from cytoplasm to mitochondria. So in the defect of the ornithine transporter, there will be the ornithine will be accumulated in the cytoplasm. There will be the hyperornithemia. There will be the hyperammonemia as well, and there will be the homocystinuria, because in the absence of the ornithine, the liver hepatocytes will clump the lysine with the carmyl, and which will lead to the homocystinuria. And for the next disorder is the citrullinemia type 1, where it is the deficiency of arginosuccinate synthase. Arginosuccinate synthase is doing what? Arginosuccinate synthase is doing ornithine plus aspartate to form the arginosuccinate. Defect in this enzyme will lead to the high blood levels of ammonia and citrulline. And there is citrullinemia type 2. There is a defective protein citrine. In defective protein citrine, there is the less deficiency of the aspartate. Aspartate is coming from the citric acid cycle or the tricarboxylic acid cycle. So it will lead to the eventually lead to the fatty liver and cholestatic intrahepatic cholestasis. Now the arginine aciduria. This occurs due to the arginine lyase deficiency. And the main clinical feature of that deficiency is the friable tufted syndrome, the trichrosis nodosa. That is the hair cells. Our hairs break easily in that diseases. The hair become brittle in this disease, trichrosis nodosa. And for the hyperarginemia is due to the deficiency of the arginase enzyme. Arginase is doing what? Arginase is cleaving the arginine to form the urea and the ornithine. Now, in defect in the arginase deficient and defect in the arginase enzyme will lead to the spastic gait also. Now this is the summary of the Urea cycle that I have described. The CO2 plus NH4 in the form of carbon phosphorus, carbonyl phosphate, to citrulline, to arginosuccinate, to arginine, to ornithine, to ornithine by the ornithine transporter to ornithine to carbonyl phosphate. Now the treatment. Basically, the treatment of all the Urea cycle disorders is more or less same. In the Urea cycle disorders, there is we have to secrete the ammonia in a soluble form. So we incorporate the patient phenyl benzoate. Phenyl benzoate will do what? In the excess of the ammonia, in the hyperammonemia state, when there is excess of ammonia in the blood, the phenyl benzoate, that is a pro drug, that is the precursor drug or inactive form of drug. Inactive form of drug that will lead to the phenyl benzoate to phenyl acetate, and that phenyl acetate can be easily secreted through the urine by the activity of the glutamine, that is phenyl acetyl glutamine form. So, that's it.
What?
Thank you, sir.
Anyway, presentation was good. You answered almost everything, but it has been lengthened by you. You could have made it short. Number one, you could have just started the slide with the overall urea cycle, because you have been studying urea cycle from class 8 standard, right? Class 8 onwards. So everyone knows about urea cycles. Prior to discussion of urea cycle, we begin the discussion about urea cycle, you must mention the production of ammonia and the relation of urea cycle to the eradication of ammonia from the body. Is it possible, like the hyperammonemia type 1? How do you treat hyperammonemia type 1?
So in hyperammonemia type 1, there will be the excess level of ammonia in the blood plasma.
How do you treat it?
Sir, I'll incorporate the patient with phenyl benzoate. So phenyl benzoate in the blood, it will bind to the phenyl glutamine. To phenyl acetyl glutamine will form, and phenyl acetyl glutamine.
Sodium benzoate.
Phenyl sodium benzoate. Phenyl acetyl glutamine will excrete out of the body through urine. So ammonia level.
So if you feed sodium benzoate, what will be excreted?
Sorry.
If you feed sodium benzoate, what will be excreted?
If I fix.
Sodium benzoate, uric acid. Yeah. So see, now you go to this hyperornithinemia slide.
Hyperornithemia slide.
Now here you have written triple H. The third H stands for
Homocystinuria.
Just read.
Defective ornithine transporter. It is an autosomal recessive condition. Ornithine transporter 1 gene is affected.
What is the third H stands for? You just read. Clinical features, second line.
Homocystinuria.
Homocystinuria.
Cystinuria.
Citrullinuria. What do you say? You said homocystinuria. But you didn't homocystinuria. Which one is correct? You don't need to answer. So what I am telling, okay, fine. You are gaining the speed, but not at the cost of text. Correct? Okay. Go back to the previous slide. One slide back. Here you have mentioned autosomal recessive, autosomal X-linked. Go to the next slide. Yes. Next slide. Yes. Here it is autosomal recessive or X-linked? Huh? All autosomal recessive except hyperammonemia type 2. All are autosomal recessive. So this point is important. You know, whenever you answer any disease or its pathophysiology, whatever it is, this first line should always be mentioning whether this is genetic adjuncts. One way so that it is recessive, dominant, X-linked, autosomal. Fine. You must remember. This is very important. Slowly, when you go to the second year, third year, one more line will be added. There is a number of chromosome, which chromosome they reside in. That also will be added. Okay, that is how you can make out the difference between two diseases. isn't it? Overall presentation was good. Thank you.
Good morning, respected teacher and my dear batchmates. My name is Shrija Pal, roll number 127. Today we are presenting on the topic cardiac markers, and we will cover the different type of cardiac markers, their clinical significance, normal values, and their role in diagnosis in heart disease. Let me introduce to my group members. Sriparna 126, Sinjan 128, Shubhajit 129. Let's begin our presentation. Cardiac markers are biochemical substances that release into bloodstream when heart muscle is damaged. Each play a vital role in early diagnosis. They are mainly useful in conditions like acute coronary syndrome due to myocardial ischemia and congestive cardiac failure due to ventricular dysfunction. This marker help in early detection of myocardial ischemia along timely diagnosis and acute myocardial infarction. They are also used to monitor the disease progression and assess severity of cardiac condition over time. In addition, cardiac biomarkers help in predicting risk in cardiac dysfunction, including markers like troponins. Uh, next, Next, we move to ideal markers. What are basically ideal markers? It should have highly sensitive so that even small myocardial injury can be detected. It should have highly specificity for cardiac muscles without elevation in other diseases. It should an early rise after myocardial injury to rapid diagnosis. It should be easily measurable in blood using simple and reliable laboratory methods. It should have predictable and sustained time course. Next, we move to major cardiac markers. Major cardiac markers are sustained release into the blood when heart muscles is damaged, especially during acute myocardial infarction. What are major cardiac markers? Troponin, CKMB, myoglobin, LDH, AST, which we'll further discuss in later. Next, we move to newer cardiac biomarkers. Newer cardiac biomarkers are recently developed biochemical markers that help in early diagnosis. They are more sensitive. So, what are newer cardiac markers? Ischemia modified albumin, highly sensitive CD reactive protein, highly sensitive cardiac troponin, myeloperoxidase, pregnancy associated plasma protein A, cholinesterase, and arterial natriuretic peptide and brain natriuretic peptide. And next, I will move to pathophysiology. I would like to call Srijan.
Hello, I am Shinjan Porel, roll number 128. I am starting with the topic pathophysiology for myocardial infarction. Firstly, atherosclerotic plaque formation happens in coronary artery. The plaque ruptures and exposes the subendothelial collagen of coronary artery. Then thrombus formation happens as collagen cascade process is underway. The thrombus may partially or fully occlude the coronary artery. So blood supply decreases. Less oxygen supply causes ischemia. Prolonged ischemia causes myocardial cell necrosis. Thus, myocardial infarction happens. Now I will talk about the cardiac troponin. It is a regulatory complex involved in muscle contraction. It has two cardiac specific isoforms, troponin I and troponin T. It may be elevated in case of myocardial cell injury, myocarditis, heart failure, and renal failure. If it is elevated, it can be detected using immunoassay method. Clinical significance, it is the gold standard for detecting myocardial infarction. It rises within 3 to 6 hours of myocardial infarction, attains its peak in 12 to 24 hours and remains elevated for 7 to 14 days. It is helpful in detecting early diagnosis and risk stratification. It has some limitation also. It may rise in case of some non-cardiac condition and it is of no use after 7 to 14 days. Now there is CKMB, creatine kinase MB. It is a diametic enzyme composed of two subunits M and V. It has three isoenzymes CKMM, CKMB and CKBB. CKMB is present in cardiac muscle. It is also present in skeletal muscle. It rises in case of myocarditis, coronary artery bypass graft surgery, strenuous exercise, and myocardial cell injury. If it rises, it can be detected using immunoinhibitory method. Clinical significance, it is one of the best marker for myocardial infarction. It rises within 3 to 6 hours of myocardial infarction, attend its peak in 18 to 24 hours and remains elevated for 2 to 3 days. It is helpful in detecting early diagnosis. Now, it has also some limitation. It is of low specificity than troponin, as it can be elevated in skeletal muscle injury also, and it is of no use after 2 to 3 days. Now there is myoglobin. It is an outdated cardiac marker as it has very low specificity. It can be elevated also in case of skeletal muscle injury and intravascular hemolysis. It levels rises within 1 to 2 hours of myocardial infarction. So it is very helpful in detecting early diagnosis. A negative myoglobin test excludes the possibility of myocardial infarction in patient of acute chest pain. It is of low use in nowadays as it has very low specificity. It, it is detected using immunoassay method and its normal serum level is 30 to 90 nanogram per ml. Now there are some older markers like LDH and AST. Lactate dehydrogenase or LDH is rises within 6 to 12 hours of myocardial infarction, and it is also very low specificity as it can also rise in case of skeletal as LDH is present in most of the tissues of our body. Then there is AST, aspartate transaminase or SGOT. It is of low specificity. It is one of the early marker for cardiac disease, and it may rise in case of skeletal muscle injury and liver injury. Now I will pass the mic to Subhajit.
Hello everyone, I am Subhajit Datta, roll number 129. So I will continue from timeline graph of cardiac markers in myocardial infarction. So here the x-axis represents the time after myocardial infarction, and the and the y-axis represents the relative concentration of different cardiac biomarkers in blood. So first of all, we discuss myoglobin. Myoglobin is the earliest to rise cardiac biomarker. It started rising around 1 to 4 hours, and it attained its peak by 6 to 9 hours and returned to its normal level by 1 day. It is a highly specific cardiac biomarker, and highly specific cardiac biomarker and earliest to rise cardiac biomarker. Still, it's not a very useful cardiac biomarker. Why? Because myoglobin is not specific at all. It may be present in both skeletal and the cardiac muscles, and it returned to its normal level just after 1 day. So even a patient came to us, even after 1 day we can't detect it. Now second is the CKMB. CKMB is a useful cardiac biomarker. Why? Because it is moderately specific and sensitive. It rises around 3 to 6 hours, attain its peak by 18 to 24 hours, and return to its normal level just after 2 to 3 days. It returned to its normal level by 2 to 3 days. So it can be useful for detecting the reinfractions. Now the troponin I and troponin T. The troponin I and troponin T are the gold standards of the cardiac biomarkers. Why? Because they are highly specific and they are highly sensitive. They started rising around 3 to 6 hours, attain their peak by 1 day, and return to they remain elevated for several days. So they are best cardiac biomarkers. A question may arise, which is the most sensitive cardiac biomarker. So the troponin I and T both are sensitive, but the troponin I is most sensitive cardiac biomarker because the troponin T can be increased in certain skeletal muscle injuries. Now the LDH1 and AST, they are older biomarkers. They are not used nowadays. Why? Because they are not at all specific. They can rise in the skeletal muscle, liver injuries, and renal pathologies. So, and they are less specific. They started rising around 24 hours and attain their peak by 48 hours. So, they are not useful at all. Next. So, what I discussed in the previous slide, I just summarized in this table format. Next. So, the clinical significance of the cardiac biomarker. First is the diagnosis of the acute Myocardial infarction. So, In case of the acute myocardial infarction, the myocardial cell injury releases the troponins. What are the troponins? The troponins are cardiac troponin I and cardiac troponin T. As they are most sensitive cardiac biomarkers for most specific cardiac biomarkers for acute myocardial infarction, their elevated levels confirms myocardial infarction. Now, next is the detection of the reinfarction. As I discussed earlier, CKMB returned to its normal level by 2 to 3 days, so it is the best cardiac biomarker for detecting the reinfarction. Next is the prognostic assessment of in acute coronary syndrome. So, what is the prognosis? It is the just predicting the future outcome of the disease. So, the greater myocardial injury releases more amount of the cardiac troponin, as so the higher amount of the troponin suggests extensive cardiac damage, and extensive cardiac damage associated with the increased rate of heart failure, arrhythmias, and mortality. Now, the monitoring the reperfusion. If we reopen the coronary artery blockage, the blood will reperfuse to the myocardial cell, and it increase the trapped cardiac biomarker in the blood. So their rise after the thrombolysis or PCI indicates successful reperfusion. Next is the diagnosis of monitoring of heart failure. So if there is a heart failure, the ventricles are unable to pump blood. So there is an accumulation of the blood in the ventricles, and gives rise to stretching of the ventricles, release of the B-type natriuretic factor, and anti-proBNP. So their levels suggest elevated. Their elevated levels suggest ventricular dysfunction. Now the myocarditis. Inflammation of the heart damages the myocardial cell. So this releases the cardiac troponins, and their elevated levels suggest that there is a myocardial injury due to inflammation. So now I will hand my mic to Sriporna. Thank you.
Good morning, everyone. I am going to continue from here. My topic is limitations of the cardiac markers. So, usually troponin is used to detect cardiac failure or heart injuries, but in some cases it might also be falsely elevated. The cases are chronic kidney diseases. In chronic kidney disease, it may be elevated because there is without myocardial infarction, because there is reduced renal clearance, and which contributes to persistent elevation, and thus interpretation requires with ECG and measurements of symptoms. Then we come to skeletal muscle injury. Now, skeletal muscle injury may be caused by muscle trauma or any other muscular injury, and thus it may lead to CKMB elevation, which is another very specifically for cardiac injuries. But in this case, it is used for skeletal muscle injury, and thus we can conclude also that troponin is much better cardiac marker than CKMB by this case. And then we move on to sepsis. Sepsis may be caused by cardiac markers due to myocardial stress or inflammation. Troponin elevation can occur without coronary artery blockage also, detecting that there is in presence of cardiac failure or heart diseases, but actually it is not. Then we move on to the recent advances. The recent advances are that high sensitivity troponin assays and point of care testing. High sensitivity troponin assays detect very low levels of troponin and then allow earlier diagnosis of myocardial infarction. Improved sensitivity helps in myocardial infarction, which is more than within 1 to 3 hours we can detect the myocardial infarction, and thus it is very helpful. The second case is test of point care testing, which is bedside testing, which can be helpful for patients who are very old or in wheelchair. Troponin, CKMB, and BNP are measured and reduces time and are helpful for the patient management. So in conclusion, I would like to say that cardiac troponins remain the gold standard measurement of cardiac injury or failure, but in some cases it may increase, and thus due to their accuracy, reliability, and clinical significance, myocardial injury can be detected. And these are essential for early diagnosis, risk stratification, and guiding appropriate management. Thank you. these are the references used by us for preparing the entire presentation.
Two clinically relevant things I will tell you. One is myoglobin. It is definitely the earliest marker, but it is not extensively used. You inquire from any hospital, any laboratory, it is not used that much because this is a non-specific test. Very specific test what you have mentioned, troponin I and tropin, then trop T. These two kits are available, number one. Number two, myoglobin is a costly test. Myoglobin test is a costly test. POCT is a costly test. In contrast, troponin I and troponin T is less costly. That is another big issue, and that has been extensively used. The myoglobin is non-specific in the sense that it is also released from the muscle. Usually, when the patient comes to the hospital, the reality is that maybe he might have taken a single injection, or on that after taking injection has pressed too much. So there is some amount of muscle damage which has been created, and that will cause a false elevation of myoglobin. That is number one. And number two, while you are interpreting a myoglobin, you must inquire about the myopathy or past history of increased CPK level in a given individual. That is, huh? প্রেজেন্টেশন তো ভালো হয়েছে, প্রেজেন্টেশন নো ডাউট ভালো, প্রেজেন্টেশন ঠিকঠাক আছে। আর একটা কথা বলে দিচ্ছি, একটা কেসে রিয়েল কেসে আমি একটা বিপদে পড়েছিলাম, সেটা তোমাদের শেয়ার করছি।
পরে শেয়ার করো। আচ্ছা, so তুমি go to the slide, previous slides. Where you have just, I think first or second slide, where you have given the modern day markers, all lists. Here. Just forward. Give the graph, timeline. See, when the cardiac marker comes, this is the slide where you have to spend more time. Okay, this is a slide where you spend more time, and always make whenever you're writing the answer, always make the chart of this. Okay, and mention which one is useful for which purpose. Myoglobin is obsolete. You may not mention. It doesn't matter. CKMB you have to mention because it is. CKMB is done commonly. Trop I is done commonly. Trop T was there, but now it is replaced by Trop I. Okay, so LDH1 is done. AST is done still till date. Okay, so these four are done always. Remember, so these four you must mention that if the onset of chest pain is one week back, then which will be more useful. So early and late markers you have to divide like this: early markers and late markers. Cardio markers are based on two: early markers where CKMB, Trop I, myoglobin all will come, and late markers LDH and AST will come. Fine. Fine.
Good morning, respected professors and my dear batchmates. I am Sumaya, roll number 133. Today our group is presenting a seminar on the topic of enzyme inhibition. First of all, I would like to give a brief description. 133. 133. Before we begin, I would like to give a brief description on the topic of enzyme inhibition. So, what is enzyme? Enzyme is a biochemical catalyst which speeds up biochemical reaction in our body without being consumed. So, their activity can be decreased or completely stopped by certain substance known as enzyme inhibitors. Enzyme inhibition is a important topics in our biochemistry because it helps regulate many metabolic pathways in our body, and it also forms the basis of various action of drugs and toxins. So now let's moving on to the type of enzyme inhibition. Enzyme inhibition is broadly classified into three types: reversible, irreversible, and allosteric types. So now moving on to reversible enzyme inhibition. So in which inhibitor binds with enzyme active site as it is temporarily bind and through non-covalent bond. So as it is reversible, it can dissociate from the enzyme and enzyme can regain its own shape again and activate. So reversible enzyme inhibition is further divided into three types: competitive, non-competitive and uncompetitive inhibition. So now let's move on to competitive inhibition, in which inhibitor and substrate competes with each other for the active site of the enzyme, and as both cannot bind at the same time, so it reduces the rate of the reaction. So, as we can see, inhibitor molecule sits into active site, competes with the substrate. So now let's see the graph. As we can see, in x-axis the substrate concentration and
Talk to the mic.
y-axis is the reaction velocity. So as we can see, the curve shifting towards the right side on the higher substrate concentration. So to achieve the maximum velocity, so that's why Vmax is unchanged. As
What is this graph about?
What?
What is this graph about? These two graphs, are they separate or different or same?
Same. One is Lineweaver-Burke plot and one is Michaelis-Menten graph.
One is Lineweaver-Burke plot, another is
Normal competitive inhibitor.
normal graph, and this is abnormal graph.
No, Lineweaver-Burke plot.
Go ahead, go ahead. So what is the difference? You should take the account of only one type of graph. You take only Lineweaver graph plot. Okay, you don't go for this. Take this one.
So as we can see here, y-intercept is the same, that means Vmax is the same, and the x-intercept is shifting towards the origin, that means Km is increasing. So now let's moving on to the example of competitive inhibition, in which succinate is the substrate and malonate is the inhibitor, and enzyme is succinate dehydrogenase. As we all know, in Krebs cycle, succinate is converted into fumarate by the enzyme succinate dehydrogenase. But in this case, malonate is the inhibitor, but it cannot be converted into fumarate because of its structural shape. So clinical useful of competitive inhibition, one is statins. As we all know that it is a blood cholesterol lowering agent, so it can be used in treatment of hyperlipidemia. One is allopurinol, which inhibits xanthine oxidase by decreasing uric acid production, so as it can be treated.
Now another mistake. You started with reversible inhibition, under which one subsection is competitive inhibition, and you have given examples where these are suicide inhibitions. They are not reversible. Continue.
So allopurinol is inhibited by xanthine oxidase by decreasing uric acid production. So it used in treatment of gout, and methotrexate is inhibited by dihydrofolate reductase, which can be used in cancer treatment, and diflumaral, which is inhibited by vitamin K epoxide reductase, which is used in anticoagulant to prevent blood clot formation. So now Sujit will continue with the next topic. Thank you.
Good morning, everyone. My name is Sujit Jana, roll number 132. I am continuing from there. Non-competitive. Today my topic is non-competitive inhibition and suicidal inhibition. Non-competitive inhibition. There is no structural similarity between the substrate and inhibitor. So there is no competition between them to bind to active site of the enzyme. So inhibitor bind to allosteric site of the enzyme. Allosteric site is site other than the active site. So due to the binding of the inhibitor with allosteric site, there is the configurational change in the active site of enzyme. So substrate is not bind there. Substrate is not bind there. And the inhibitor and substrate bind at different site. So there will be formation of the inhibitor, enzyme inhibitor and enzyme inhibitor complex is possible. But enzyme inhibitor substrate which produce product at slower rate. But enzyme inhibitor complex will not produce any product. There is the enzyme. There is the enzyme inhibitor bind to the allosteric site of the enzyme. It causes the configurational change of the active site. So substrate region bind there. It causes non-competitive inhibition. When the substrate is bind in presence of inhibitor, it causes product, but it formed at slower rate. As there is no competition between the inhibitor and substrate, so inhibitor does not interfere with the binding of substrate with enzyme. So Km value remain unchanged. As with increase the concentration of substrate, inhibition does not overcome. So Vmax is decreased. So there is the graph of non-competitive inhibition. In the presence of inhibitor, we see that the Km value is remain unchanged and Vmax value is decreased. There is the example of non-competitive inhibition. The cyanide inhibits the cytochrome oxidase, and the fluoride inhibits the enolase, and the heavy metal like argentum lead inhibit the cysteine containing thionine containing enzyme. Suicidal inhibition. Suicidal inhibition is specialized form of irreversible inhibition. Here, this is also called the mechanism-based inactivation. It causes due to inhibitor use its own enzyme reaction to inhibit it. In inhibitor, in presence of enzyme, transform into the more effective inhibitor. It so causes inhibition. So, enzyme literally committed to suicide. There is the example. Allopurinol is the inhibitor. Enzyme is the xanthine oxidase. With the help of the xanthine oxidase, allopurinol is converted into alloxanthine. Allopurinol is converted into alloxanthine, more effective inhibitor, which causes the inhibition of the xanthine oxidase. Then the aspirin, which is also used in gout. Aspirin inhibits the enzyme cyclooxygenase. Cyclooxygenase causes the conversion of the arachidonic acid to prostaglandin. Aspirin acidylates the serine residue in active center of cyclooxygenase. So prostaglandin synthesis will be hampered. This is also used as the NSAID, non-steroidal anti-inflammatory drug. The next example is the DMFO, difluoromethyl ornithine. Inhibits the ornithine ornithine decarboxylase, which causes the conversion of the ornithine to putrescine. So the putrescine synthesis will be hampered. This is also used in the therapeutic drug in the sleeping sickness. Next, we move slide to the Sujit Jadhav. 132.
Good morning, everyone. Myself, Sujit Yadav, roll number 131. So now let's talk about uncompetitive inhibition. It is a type of inhibition in which an inhibitor attaches to the enzyme substrate complex, not to the free enzyme. In this case, substrate must bind first before the inhibitor attaches to it. This inhibitor attaches at a site different from active site or allosteric site. This causes the structural distortion of active site, making the enzyme catalytically inactive. Since the inhibitor does not compete with substrate, addition of substrate does not reversify the inhibition. As we can see in diagram, first the substrate attaches to the enzyme, then inhibitor attaches to the enzyme. In presence of inhibitor, both Vmax and Km decreases. As we can see in another graph, both Michaelis constant and maximum velocity decreases proportionally. So now let's talk about irreversible inhibition. It is a type of inhibition in which the inhibitor permanently inactivates the enzyme. Inhibitor forms a strong covalent bond with the enzyme, making its structure permanently changed. Enzyme activity cannot be enzyme activity cannot be regained by addition of substrate or dialysis. Now Surbi will explain the rest.
Good morning, everyone. My name is Surbhi Singh, roll number 135. Now, coming to the allosteric inhibition, some enzyme shows additional site other than the active site. They are known as allosteric site, and the enzymes are known as allosteric enzymes. They are unique site on protein molecule. Allosteric effectors are substances which bind to allosteric site and regulate the enzyme activity. Positive allosteric effectors increases the enzyme activity, whereas negative allosteric effectors decreases the enzyme activity. Allosteric enzyme shows sigmoidal curve. Here in this graph, we can see the S-shaped sigmoidal curve where the Km value is increased and the Vmax value is reduced. Coming to the negative inhibition, it is a specialized type of allosteric inhibition required to control the metabolic pathways for cellular functions. End product of metabolic reaction produced in excess inhibits the first or regulatory enzyme in the sequence. The end products are controlling their own rate of production. Here we can see the substrate D is formed in excess amount, which loops back and inhibits the enzyme 1 activity. Now coming to the examples of negative inhibition, it is seen in heme synthesis where the enzyme ALA synthase is inhibited and heme is produced. Cholesterol synthesis where HMG coenzyme A reductase is inhibited and cholesterol is formed. Glycolysis where the hexokinase is inhibited and glucose 6-phosphate is formed. And it is also seen in fatty acid synthesis and pyrimidine synthesis. Thank you.
There are many mistakes. You have mixed the competitive along with irreversible. Suicide 1. Allopurinol. How do you classify allopurinol? Competitive or suicide inhibition? Myoglobin.
Suicide inhibition.
Then you have put under competitive. It is not competitive. What is the difference? Allopurinol itself is not identical to the substrate. When it converts to alloxanthine becomes more close structure to xanthine. And this conversion takes place within the enzyme. So it is not competitive. So remember, these are very big mistakes. Big mistakes.